I was asked to talk about head and neck cancer, and it's a very diverse type of tumor, so I will focus my remarks mainly on squamous histology. These are my disclosures. So for the next half an hour, I will talk about, give an overview of head and neck cancer management, to discuss the role of treatment de-escalation in HPV-related oropharynx cancer, which is mainly those arising in the tonsil and the back of the tongue, and to discuss the role of immune checkpoint therapy, mainly the PD-1 pathway targeting in head and neck cancer. So when we talk about head and neck cancer, we talk about tumor arising from the mucosa, from the nasopharynx, down to the top of the esophagus. Some of the tumors are shown here. Together, they form the 9th most common cancer globally, and the incidence is rising, and 7% of all cancer worldwide. Many of these patients also present with nodal metastasis up front because these tumors are very rich in lymphatic network. The causes of head and neck cancer are commonly known in the past with tobacco, betel nut chewing, and alcohol. We now know that HPV, especially 16 and 18, can cause oropharynx cancer, and EBV can cause nasopharynx cancer. Other contributing factors including diet, poor dentition, probably the microbiome, and radiation. This is a very simplistic view of treatment modality in head and neck cancer. Usually we use surgery, radiation therapy, and systemic treatment, which is primarily chemotherapy and more recently immune checkpoint inhibitor. For early stage cancer, stage 1 or 2, we treat them with single modality therapy, which is surgery or radiation, except for the latest AJCC staging system, which I will talk about, where stage 1 is treated oropharynx cancer with nodal involvement treated with chemoradiation. Whereas stage 3 or 4, locally advanced non-metastatic cancer, we treat them with bi or trimodality therapy, usually surgery followed by radiation, or chemoradiation, or all three. For patients with metastatic disease, usually 20% of these patients present with metastatic disease. They get chemotherapy, but I'll show you data for upfront immune checkpoint therapy. So in the last 25 to 30 years, we have a tremendous improvement in imaging for head and neck cancer with PET-CT, now identify patients with either concurrent cancer or metastatic disease. The introduction of robotic surgery have decreased morbidity for these patients. The introduction of intensity modulated radiotherapy in radiation, targeted therapy, more recently immune checkpoint therapy. We're learning more about these tumors, especially through the CTGA project, the genomics of these tumors, and we're also learning more that these patients need supportive care after treatment. With that, we've seen about 10 to 20% improvement in survival over the years for these patients, and with less morbidity, with treatment-related morbidity. The group at Hopkins about 20 years ago introduced the HPV-related oropharynx cancer. Again, these are tumors that arise from tonsil and base of tongue. They're mainly HPV 16 and 18. They also introduced the concept that these patients tend to be younger, non-smoker, more responsive to traditional therapy, so do better. With 2 large RTOG randomized trials, I also run the RTOG head and neck committee. We've identified patients who are low risk, intermediate, and high risk patients and validated from one to the other. The low risk patients are the HPV-related head and neck cancer with non-smoker, less extensive primary and nodal disease. Their survival is in the order of 90%. The intermediate risk are those with HPV-related cancer, smoker, or larger tumor, more extensive nodal disease. Their survival is in the order of about 60 to 70%. And the high risk are those with HPV negative cancer with a survival rate about 30 to 50%. So based on these data, the AJCC staging system has changed in this year, version 8. Patients with HPV-related cancer are now a different stage than those with HPV negative cancer. So patients present with nodal metastases are now stage 1 instead of stage 3 or 4 or stage 2. So that brings up the controversy of how we treat these patients. They have better prognosis, however, they were treated with combined modality therapy. So there's a very strong interest in treatment de-escalation for these low to intermediate risk patients. I will talk to you about the result of 2 large randomized trials that was just recently presented at ASTRO and ESMO and in Breast at Lancet Oncology. One of them is run by RTOG, by our group, and the other one's by the UK group, trying to replace cisplatin and cetuximab. The other strategies to decrease treatment for these patients is either with induction chemotherapy in order to reduce the radiation dose or field, either was in highly selected patients, decrease the radiation and chemotherapy together or remove chemotherapy, or using surgery up front with reduction of radiation dose. These trials tend to be single, smaller trial, and they have not mature data, and we introduced to you some of the trials, but do not have the results. So if you look for the last 20 to 30 years, we've shown that when we add cisplatin to radiation, it is superior to radiation alone, with about 8 to 10% survival advantage in several randomized trials. We also know that when we add cetuximab to the radiation, it yielded about 8 to 10% survival advantage over radiation alone. That's known as the Bonner trial. The benefit for both of these drugs appear to be independent of HPV status. Radiation cetuximab did not appear to worsen the quality of life compared to radiation alone. So our hypothesis is that radiation and cetuximab is non-inferior to radiation and cisplatin with potentially less toxicity. And so that led us, in 2010, mounted this large Energy Oncology RTOG 1016 comparing the 2 treatment regimen. So patients with HPV positive cancer, so these are only HPV positive oropharynx cancer, were randomized to radiation and cisplatin versus radiation cetuximab. We needed about 800 patients to yield a one-sided 5-year survival of one-sided upper confidence interval for the hazard ratio of less than 1.45 in order to say that cetuximab is not inferior to cisplatin. Other primary endpoints including toxicity and function for these patients. It was a very easy trial to accrue to. Within 3 years, we accrued over 800 patients, but it took 4 years for all the events to come in. And so we just presented this trial 3 weeks ago at ASTRO, and it's now in Breast at Lancet. As you can see, these patients are generally younger than your average head and neck cancer patient with median age of 58, primarily male, most have great performance status. 40% of these patients are current smoker or heavy smoker, and 71% were considered low risk by our TOG 0129 risk group trial. So if cetuximab were non-inferior to cisplatin, it should fall within the blue bar, as I showed here, between 1 to 1.45. Unfortunately, the actual is a red line. The upper hazard is 1.94. Numerically, overall survival, progression-free survival, local regional failure was significantly superior with cisplatin. There was also a trend to less distant metastasis with cisplatin. The difference in survival is approximately about 7 to 8%. Here's the survival curves for overall survival. You can see that the patient with cisplatin maintained a 5-year survival of 90% plus at 85%, and progression-free survival of 78% compared to cetuximab. The primary pattern of failure continued to be local regional for these patients, 10 versus 17%, and there was a trend to increase distant metastasis with cetuximab. If you look at the forest plot and see which patient population may or may not benefit from cetuximab, it seems like cisplatin tend to do better for cetuximab for all patient population, even with the patient with low risk group, or now we consider the AJCC stage 1 patient. Toxicity was no difference between the 2 arms for radiation-related toxicity. Cisplatin had more nausea, vomiting, hearing, renal, and hematologic toxicity. Cetuximab had more skin and rash toxicity. So that's what we consider the classical worst grade toxicity. If we use the acute toxicity burden, which we coined through RTOG, which is the T-score, every single time the patient have an episode toxicity we count, there was a 40% increase in acute toxicity with cisplatin. However, when you look at late toxicity, there was no difference in late toxicity between cisplatin or cetuximab, except for hearing, which was more with cisplatin. If you look at the total late toxicity burden, there was no difference. If you look at swallowing function for these patients, whether physician-reported outcome, patient-reported outcome, or feeding tube use, there was no difference between the two arms. While we presented this data at ASTRO, at the same time at ESMO, the group from UK presented their trial of De-Escalate by Hisham Mehana. So De-Escalate is the same exact design as RTOG 1016, and here the primary outcome is, instead of survival, is severe toxicity. With 300 patients, they plan to detect a greater than 25% grade 3 to 4 toxicity in terms of reduction with cetuximab. Because they look at toxicity, therefore they were able to use a smaller sample size. So if you look at grade 3 to 5 toxicity in De-Escalate, there was no difference between the two groups. Cisplatin did cause more severe adverse events that were reportable compared to cetuximab. There was no difference in global quality of life for these patients. There was no difference in swallowing function. Interestingly enough, even with 300 patients, they were able to detect a significant difference in survival, favoring cisplatin. All recurrence, well, mainly they have more local regional recurrence and distant metastasis with cetuximab. Here are the survival curves. The difference was noted for both stage 1 and 2, as well as stage 3 patient AJCC version 8. So in summary, the two trials, back to back, and I think De-Escalate is also coming out Lancet as well. We have established that cetuximab is indeed inferior to cisplatin. Cisplatin had better overall survival, progression-free survival, local regional control, and possibly distant metastasis. The classical overall acute toxicity was no different. The acute toxicity burden, serious adverse event, was more with cisplatin, but more importantly, the late toxicity and swallowing function was no difference. So cisplatin unfortunately remained the standard of care for these patients with good risk HPV-positive tumor. The ECOG, which is another cooperative group in North America, took a different route. This is a smaller study. It's a 100-patient study where they give patients with induction chemotherapy triplet. Patients have a complete response. They reduce the radiation dose to 54 grade with cetuximab, whereas a patient with incomplete response, they give a full dose. What they've identified is the best results with those patients that were non-smoker with smaller burden of disease, smaller nodal disease. They have a 2 years overall survival of 96%. The rest of the other patients did worse. So they've identified a very good risk group of patients, and based on that, RTOG and Energy Oncology, we proceeded with a large 300-patient randomized trial, just a very highly selected patient based on the ECOG study, and randomized them to 60 grade with radiation, so 10 grade reduction of radiation with chemotherapy versus 60 grade radiation alone. We've complete accruing this study within a year, and we're still waiting for events to come out. ECOG did a different randomization. These are patients were treated with transoral resection, either with a robot or laser. Patients who needed radiation therapy, they randomized them to either 50 grade versus 60 grade. Again, a 10% or 10 grade difference reduction in radiation dose. They've accrued 500 patients. We're still waiting for event to come in. So far I've talked to you about locally advanced HPV-positive tumor. The treatment had been surgery, radiation, and chemotherapy traditionally. Within 2000, immunotherapy has started to surface in head and neck cancer. Head and neck cancer is a highly mutated tumor. And interestingly enough, the mutation rate is very similar with HPV positive and HPV negative tumor. However, they have a different pattern of mutation. For HPV negative cancer, it tends to be more transversion with CPG, and for HPV positive tumor, TPC mutation. They've also have different alter network. P53 signaling, oxidative stress, and cell cycle pathway were more common in HPV negative cancer, whereas DNA damage repair were more common in HPV positive cancer. We also know that PD-L1 expression is high in head and neck mucosal tumor, mainly on the tumor cells or in the immune cells within the tumor microenvironment. And the overexpression of PD-L1 expression on the cell membrane of any of these cells confer worse outcome. So that's the rationale for testing immune checkpoint therapy, essentially PD-1 antibody, nivolumab, in patients with recurrent metastatic squamous cell carcinoma of the head and neck. So these patients have what we call second-line setting. They have failed cisplatin, the first-line cisplatin chemotherapy. And the randomization is standard of care, which is either single-agent methotrexate, docetaxel, or cetuximab, versus nivolumab, which I will call Nivo. The primary endpoint is overall survival. You can see here, over 300 patients were randomized, 2-to-1 randomization. At 2 years, at 1 year, the survival is 20% for standard of care versus 34% for nivolumab. The difference held up for 1.5-year outcome. Toxicity was much less with nivolumab, and that led to nivolumab approval for the FDA in the US a couple years ago. At the same time, KEYNOTE-040 was also running, and this time it's exactly the same design, but it's replaced by a different anti-PD-1 antibody, pembrolizumab, which I will call Pembro. And when this trial was first analyzed, the difference was 10% in survival at 1 year, 27 to 37%. The p-value of 0.02, but it was not considered statistically significant because they have multiplicity testing. So they looked into that, and when the study was being ongoing, nivolumab was approved in the US. So there was 12% patient crossover to receive immune checkpoint therapy. And if you were on the standard treatment and you cross over to receive immune checkpoint therapy, you have better survival than if you continue on with standard chemotherapy. And so they decided to do was to censor the patient at the time of first subsequent immune checkpoint therapy. And with that, the p-value now become 0.001 and considers to be statistically significant. And Pembro is also approved by the FDA for second-line treatment in the US. So there's an interest right now to move these agents into the first-line recurrent metastatic setting as well as a local regional advanced setting. And the rationale for moving it in with chemotherapy is that chemotherapy can disrupt the tumor architecture. It may increase antigen shedding. It may overcome immune exclusion. But at the same time, in head and neck cancer, you need rapid disease control because they can get out of hand pretty soon. So KEYNOTE-048 is a trial that was conducted and actually just reported by ESMO 2 to 3 weeks ago. This is a trial where they randomized 900 patients, 3 patients per arm, to the standard first-line chemotherapy for recurrent metastatic setting, and that's platinum-based chemotherapy plus 5-FU plus cetuximab, compared to pembrolizumab alone or pembrolizumab plus chemotherapy. Patient was stratified by PD-L1 expression within the tumor cell as well as immune cells, P16 status, and ECOG performance status. Their hypothesis is that tumors that have high PD-L1 expression within the tumor microenvironment, either the tumor cell or the immune cell, they call it CPS. The Pembro may have better survival compared to chemotherapy. And in the overall population, regardless of PD-L1 expression, the addition of Pembro may be better than chemotherapy alone. So here's the result. In patients who have the CPS, which is, again, PD-L1 expression in the tumor cell or immune cell, more than 1% or more than 20%, there was a significant improvement in survival, single-agent pembro versus triple-agent chemotherapy. 2-year survival for the 20% going from 22% to 38%. There was no difference in progression-free survival. There was fewer response rate with pembro alone, but for those patients who respond, the response duration was more durable, much longer. And most interestingly, toxicity was very little in the pembro single arm compared to triple-agent chemotherapy alone. In those who were randomized with pembro plus chemo versus chemo alone, regardless of PD-L1 expression within the tumor or the tumor immune cells, there was an improvement in survival at 2 years from 18% to 29%. Again, there was no difference in progression-free survival. Response rate were the same, but more durable response with the addition of pembro. And interestingly enough, there was no increase in toxicity when pembro was added to chemotherapy. So the conclusion of KEYNOTE-048 trial is pembro had significantly improved survival with less toxicity compared to first-line chemotherapy in patients with recurrent metastatic head and neck cancer and with the positive PD-L1 expression in the tumor and immune cells. The addition of pembro to first-line chemotherapy significantly improved survival with comparable toxicity profile in all patients with recurrent metastatic head and neck cancer in the first-line setting. So the data support for a biomarker-based approach for integrating pembro into the first-line treatment of recurrent metastatic head and neck cancer, while waiting for the manuscript to come out. So based on that, we're now moving these agents even earlier into the curative setting. If you look at the clinicaltrial.gov search, there were at least 24 phase 2-3 trials testing integrating PD-1 or PD-L1 antibody in non-metastatic head and neck cancer from stage 1 to 4. And to highlight here are just 5 different trials. They're all very large trials, 400 plus patients, randomized patients to either chemoradiation with concurrent and adjuvant treatment of these agents or adjuvant treatment of these agents like the Pacific approach in lung cancer. We don't have the data for these trials. Some of them are about, I think, halfway into accrual. Hopefully we'll hear about them in a year or 2. So in conclusion, I hope I've shown you that head and neck cancer is a very heterogeneous disease, despite its similar appearance under the microscope. I think precision therapies are slowly arriving in head and neck cancer in the form of more precise surgery, radiation therapy, biomarker telesystemic therapy. Immune checkpoint inhibitor, it can improve survival in patient recurrent metastatic setting and is being tested in the earlier setting. And hopefully clinical trials will translate into improved survival and quality of life in head and neck cancer survivor. I'd like to thank all the patients who participate in the clinical trial, especially RTOG 1016, the Energy Oncology, previously known as RTOG, Head and Neck Committee. Dr. Kian, my predecessor as a chair for the committee, I took over for him in 2011. I'd also like to thank my colleagues, Dr. Mehana, Cohen, Burgess, and Bob Ferris, who gave me some of the slides to present here today. Thank you.
So thank you for that terrific summary of the state of the art. Are there any questions from the audience? I have one question, maybe just start off about what you think the role of cetuximab is at this point. And also in Kian's original study of EGFR expression, I mean, he basically showed there were differences in outcome depending on the level of expression. Did you stratify for the level of expression of EGFR in the cetuximab versus cisplatin trial?
Yeah, so we, in a prior study, 0522, when we added cetuximab to cisplatin, we did stratify it. We did not see any difference with EGFR expression using the quantitative analysis. So because of that, we did not stratify it here. I think the question, as you know, EGFR parent pathway tend to be more an HPV negative tumor. So the question is it better in HPV negative versus HPV positive cancer. We went back to, the Bonner study. They went back and they looked at 50 patients based on HPV status. They concluded that everybody benefited. And so that's why we went off to do this study. I think the cetuximab is still being used for patients who cannot tolerate cisplatin. The question is whether it's carboplatin versus cetuximab versus a taxane or something like that.
Thanks for an excellent talk. I wonder whether you have any idea as to why HPV positive cancer is so radiosensitive. Is there a mechanistic understanding of this that you could share with us?
Yeah, I think it's the activation of, there are definitely more changes in DNA repair pathway in HPV positive cancer. And so maybe they're just a little bit more sensitive because they have a lot more DNA damage in them. But a lot of the studies have looked at cell lines, and there's definitely more sensitive into clonogenic survival. Some, pathway would look at STAT, et cetera, but there's really no consensus why they're more sensitive.
And is there any difference at all emerging in the response to the benefit for immunotherapies between the different etiologies?
Yeah, so if I didn't have this time to show, but people have looked at the NIVO trial and also the PEMPO trial. It seems like both HPV positive and negative benefit with immune checkpoint therapy. The hypothesis is because you have more inflamed tumor phenotype in the viral-driven tumor, whereas you have more mutational changes in the HPV negative, even though the total mutational load across the cohort may not be the same, but people who smoke tend to have more mutational load, so that tend to be maybe the HPV negative tend to be more smoker and more mutational burden.
Are there any other questions? If not, I'd like to thank Dr. Lee for a really outstanding talk that ended the conference on a high note. And good luck on your trip to Japan.
Thank you.